Okay, you're live now. Dr. Kotlar.
Yes, do you want me to start?
Yeah, it's already started. You can go ahead and get started.
Okay, hello everyone. This is Dr. Kotlar from Target Coding. I want to thank everyone at ChiroHealthUSA for inviting me to do this webinar. Today's topic is wellness care versus medical necessity. A little bit about myself before we get started. Again, my name is Dr. Marty Kotlar. I'm a chiropractor. I practiced for many years. I practiced for 16 years. And about 12 years ago, I started a company called Target Coding. I am also a certified professional compliance officer. I'm a certified billing and coding specialist. And I kind of consider myself unique because most chiropractors are not certified coders. Most certified coders are not chiropractors. So you'll see as I go through this presentation, I'm going to give you that blend of, hey, I know what it's like to be in the trenches and see patients and come up with certain diagnosis codes and CPT codes to maximize reimbursement. And then on the other hand, as far as the compliance goes, making sure you're billing and coding properly, making sure you're maximizing reimbursement, make sure you're following all the laws and rules and regulations within your state. I've written many books and training manuals on chiropractic, billing, coding, and documentation. I write articles to Chiropractic Economics, Dynamic Chiropractic, The American Chiropractor, many of the other state association newsletters. I'm a guest speaker at many state association conventions nationwide. So a lot of people, they consider me like the insurance guy. I don't consider myself the insurance guy. I consider myself the compliance guy. I just want to make sure you're billing and coding properly to maximize reimbursement. So this is a common question that gets brought up. Dr. Kotlar, how do I know the difference between medically necessary care and wellness care? You may have heard about these audits that go on where insurance companies will pay for your care, and then they go, wait, we want money back because your notes looks like it's maintenance or wellness care. So why don't we go through the difference between these two? First of all, a patient can call their insurance, right? A patient can call insurance and say, hey, I am going to see Dr. Kotlar, chiropractor. Does my health plan cover chiropractic? You know what the patient's going to hear? Yes. Just about every single health plan in just about every single state across the country includes chiropractic care. It was a mandate many years ago that every single insurance plan include chiropractic. I thought it was a good thing. I think it's a good thing. So patient calls insurance and says, hey, does my insurance cover chiropractic? They're going to hear yes. And then they might hear, yes, you're covered for 30 visits as long as it's medically necessary. So what did the patient hear? I'm covered for 30 visits. They didn't hear the medically necessary part. So I made a simple equation here. Medically necessary means insurance payable. Medicare calls it active treatment. Active treatment is medically necessary. Medicare pays for active treatment. That's why you need to use the AT modifier. So again, medically necessary is insurance payable. So when I first started practicing, if you asked me what is medically necessary, you know what I would have said? I would have said, well, the patient has a subluxation. I adjust the subluxation and the insurance company should pay me for that. Regardless if the patient has symptoms or not, the patient has a subluxation and I need to adjust that bone back into place. That's medically necessary. Well, boy, have times changed. That's not the truth anymore. It's not just because a patient has a subluxation. So this is the way I recommend you explain it to your patients. Mrs. Jones, yes, you're covered for 30 visits. Yes, as long as it's medically necessary. But let me clarify that. It's up to 30 visits. And it's as long as medically necessary. So Mrs. Jones, you know what medically necessary is? It means you have pain, you have restricted motion, you have decreased ability to do your normal activities of daily living. That's insurance payable. Now, here, look at the screen now, everyone. Then you would say something like this, Mrs. Jones, you're going to get to the point where you're going to be feeling very little pain. You're going to have very good range of motion, and you're going to be able to do most of your activities of daily living. Why? Because we know that, Mrs. Jones. We're chiropractors. Chiropractors get people well very quickly. So, in X number of visits, now here's where you have to be able to direct this, visit amount. You could base it on your diagnosis codes. You could base it on your clinical, ability to come up with a treatment plan. You could base it on the patient's financial impact. There's a lot of things that go into how many visits you think the patient is going to need, but we could all agree that chiropractic works very well, right? So patients in a certain amount of visits, maybe it's 12, maybe it's 15, maybe it's 18, patient's going to have very little pain. Chiropractic works. Range of motion is going to be great. It's no longer insurance payable. So that's one thing you should tell your patients. Mrs. Jones, yes, you're covered for up to 30 visits as long as it's medically necessary. But let's say after 18 visits, you are feeling fantastic. You have no more pain. Well, according to your health plan, it is no longer medically necessary. Hopefully the patient will understand that. And then you could say, yeah, so let's say that happens after 18 visits. So you have 12 visits in the bank for a rainy day to use for future care. Wellness care, maintenance care is not payable by insurance. And there's a difference between wellness and maintenance. Hopefully you know that. So not medically necessary means not insurance payable. Performance enhancing care is not payable. What do I mean by that? You see that hiker on the rocks there climbing up? So let's say this person comes into your office and says, I climb mountains. I just climbed a mountain. There's another mountain that I want to climb. It's much higher. I want to climb a higher mountain. I feel great. I have no pain. I have good range of motion. I'm strong, no pain. I just want to climb higher mountains. That's not payable by insurance. That's in performance enhancing care. Now, I don't know how many of you guys play golf listening to this. I don't know how many people play golf, but I play golf a little bit. And I would have a lot of golfers coming into my practice. And there were some golfers I would work on. And after a few visits, the golfer would say, let's say his name is Paul. Paul would say, hey, Dr. Kotlar, I am hitting the ball further. Just want to let you know, when I tee off, I'm hitting the ball another 15 yards. I think it's because of, you've been working on my back. Great. Paul now refers his friend. His friend Charles comes in. Hi, Charles, how you doing? Charles says, you know what? You're helping my friends hit the ball further. I want to hit the ball further. I play golf with these guys every Sunday. I want to hit the ball further. Can you help me? I would say, of course, Charles, I could help you hit the ball further, but Aetna doesn't pay to hit the ball further. So at maximum therapeutic benefit, transfer the patient to wellness. Again, that's not insurance payable. Now, here's where I think some doctors may not be explaining this transition well enough. Like if a patient says, well, my care is medically necessary, it's payable, right, Dr. Kotlar? Yes. So then some doctors go, well, Mrs. Jones, your care is no longer medically necessary. So now come in once a week and we're going to have you pay cash. The patient might say, wait a second, if the care is not medically necessary and paid by my insurance, so then why should I come in if it's not medically necessary? Change the terminology. Because chiropractic necessity, clinical necessity, is different than medical necessity. If you're a chiropractor that's looking to correct postural distortions, forward head translation, scoliosis, this is not typically covered by insurance. So you want to use the words, okay, come in. Mrs. Jones, we're going to be providing not medically necessary care, so come on in. It just doesn't work. That's wellness care. So what's medical necessity? Well, depends who you ask. Remember, you ask me, yeah, subluxation. Subluxation codes, here they are. They don't say subluxation, but these are the subluxation codes. There's traumatic subluxation codes. Yeah, I just want to show you some of the diagnosis codes here that could help you determine, is it something we can bill insurance? or is this not covered by insurance? So traumatic subluxation codes are typically covered by insurance. You see those codes that begin with the letter S? S means trauma, injury. Those are typically covered. Pain and symptom codes, yeah, those could be covered for a while, not forever. Radiculopathy, yeah. Now we're talking about long-term treatment diagnosis codes. I like to break diagnosis codes down into two categories, short-term and long-term. So if a patient has a lumbar radiculopathy, that's going to tell the insurance company that this patient needs more care than plain old muscle spasm or simple muscle strain. So I like radiculopathy codes. Disc degeneration, yeah, those could be considered medically necessary codes. Disc disorder, disc displacement. Okay, now we're talking about herniated discs, ruptured discs, bulged discs, protruded discs. Patient can come in and have no pain at all and have a disc bulge, right? There have been many studies that show asymptomatic patients going into an MRI machine, and I think 4 out of 10, I think that was the study, 4 out of 10 patients, asymptomatic patients, get into an MRI machine. 4 out of 10 will have some sort of disc pathology, but they don't have any pain. They're doing their normal activities of daily living. That's not considered covered by insurance. But most patients that come into your office with disc disorders, disc displacements, they have pain and symptoms. Again, what is medical necessity? Pain, discomfort, restricted motion, decreased ability to do activities of daily living. Some people could have herniated discs, but somebody could have scoliosis and be able to do all their normal activities. Headache codes are very good. This is a headache questionnaire. You've heard of outcome assessment forms. It's a great way to monitor progress. Hey, you think a patient might be reaching wellness, but you don't know how to explain it to them? Let them set their own fate. A patient comes in, they fill out one of these neck index forms. If the patient checks, yeah, I have, severe pain at the present, sleeping, yeah, the pain prevents me from sleeping. Yeah, my neck pain, yeah, it's difficult for me to concentrate. I have difficulty, doing my normal work because of my neck pain. I have difficulty pulling a sweater over my head because of my neck pain, right? The patient fills all that stuff out. It's medically necessary and payable. Next patient fills this neck index out, let's say on the 12th visit. You see a patient 3 times a week for a month. So on the 12th visit, you hand the patient this neck index, disability form, outcome assessment form, and they fill it out. I have no pain at the moment. I can sleep normally. I can read normally. I have no headaches. I can drive without pain. I can put on a sweater without pain. I have no pain. So now the patient has set their own fate. Treat them for a couple of more visits. And once they're stable, let them know. Let them know the good news and the bad news, right? It's good news that they could, if a patient came in and said, Dr. Kotlar, I can't even get out of a chair. My back is in so much spasm, so much pain, I can hardly get out of a chair. And then after 12 visits, the patient goes, look, Dr. Kotlar, I can get out of a chair, no problem. That's good news, right? Good news, Mr. Jones, you've reached wellness, maintenance. These are some more, I like to use complicating factors. Patient has some sort of, a comorbidity. Think about this. Patient A comes in. Patient A comes in. Patient number 1, we'll call it patient number 1 comes in just with low back pain. And now you have patient number 2 comes in with low back pain and is overweight and is taking medication for anxiety and is also has diabetes. Patient number 2 is probably going to need more care. Do you want, now, hold on. Is the patient's diabetes impacting their condition? If not, then it doesn't matter that they have a complicating factor. You see what I'm saying? If the patient has headaches, so they have diabetes. Is the diabetes affecting their headaches? If not, then it's not a complicating factor. And then you have medical necessity. Again, depends who you ask. How about you ask Aetna? Aetna has a policy, and it talks about what's considered medically necessary. If you're billing Aetna, you should know what their policy is. Do you bill Cigna? Do you have any Cigna patients? They have a policy on chiropractic. You should know. I had a client last year. He collected $700,000 from Cigna. Yes, you heard me right. I had a doctor that I work with. I have a doctor. He's been a client of mine for many years. He collected over $700,000 last year from Cigna. So what do I do with him? I have a billing and coding policy manual I've put together for him, and it specifically has a section on how they deal with Cigna. But they have a policy on chiropractic. Anthem Blue Cross Blue Shield has a policy. They have guidelines. You should read these if you are billing these insurance companies. Hey, any of you from Illinois listening to this? Yeah, if you are a chiropractor in Illinois, I would strongly recommend you read Blue Cross Blue Shield of Illinois' policy on chiropractic. Very important, good information in there. And they typically say you have to have a treatment plan, so hopefully you have a treatment plan. Anyone deal with American Specialty Health? ASH, American Specialty Health. Yeah, they have strict guidelines, and you better know them, whether you're in network or out of network. Get well trained. It doesn't take a long time. Get a training on I call it the 35% rule. If you're billing and if you're collecting more than 35% from one insurance company, then you should do a deep dive into that company and have policies and procedures on that. So when it comes to American Specialty Health, oh, Christy, are you there? It's not letting me fast. Go to the next slide. Oh, let's see if it's working now. Okay, so yeah, so Optum, a lot of you, right? A lot of doctors listening to this, you bill United Healthcare. Yes, they have a relationship with Optum. They have policies and procedures. Again, this is all what's medical necessity. I'm giving you the Medicare's definition of medical necessity. ASH has a policy on it, Aetna, Cigna. If you're billing any of these plans, know it, learn it, understand it. So you could SWAN. You ever hear that acronym? SWAN? SWAN? It means sleep well at night, right? That's what you want to do. You want to be proactive. And a lot of the information I use are from guidelines. A lot of people call me the guidelines guy because I've mastered the E&M guidelines, the Medicare guidelines, the chiropractic guidelines, the OSHA guidelines, the HIPAA guidelines. I got them all, down to a science. And these are what the insurance companies use to determine whether or not to pay you. So hopefully you do a good exam. Please do a very, very good, thorough exam. If you're going to bill insurance companies, you have to prove medical necessity, right? If you're billing insurance companies, you have to prove medical necessity. So one of the most important things to do is a very good exam. So a little bit about coding. Many of you are billing 99203. How do I know that? Because I've been working with chiropractors for the last 12 years, and we keep statistics and data, and it's the most commonly billed new patient CPT code, 99203. I'm assuming most of you are billing it. So now I'm going to share a little information with you. If you're going to bill for a medically necessary chiropractic adjustment, you have to start that little breadcrumb trail. First is the history. Mrs. Jones says, I have neck pain and back pain. She has insurance. You're going to be billing insurance. Better write down neck pain and back pain. Actually, back pain is not even a good thing. If a patient writes down, I have back pain on their initial health history form, if you have a nice, good quality health history form on that first visit, it says, what is your chief complaint? What is your main reason for today's visit? If the patient writes back pain, hand the form back to the patient and go, Mr. Jones, can you please put down, is that upper back pain? Is that mid back pain? Is it lower back pain? Why am I saying that? That could be the difference between a 98940 and a 98941. So get very specific. You're creating that, I call it creating that breadcrumb trail. If you're going to be billing insurance, you have to cross every T and dot every I. Even if you're out of network but accepting assignment, even if you're not accepting assignment, you're out of network and the patient's paying you and the checks are going to them, you're still billing and the insurance company is paying. So this is important. So go do a good quality history and then Next breadcrumb is your exam. Mrs. Jones has neck pain and back pain. Okay, we're going to do an exam. Now we have CPT codes right here on your screen. 99203 means a detailed exam. What's a detailed exam? This is according to the E&M guidelines. I'm going to be sharing information with you. This is according to the E&M guidelines. There are two sets actually out there, 1995 and 1997. What did you say, Dr. Kotlar? 1997? Yeah, they're old. Yes, they are old. They haven't been updated since 1997. They're going to be updated. They started the update already. You're going to see some changes in the next year or two to E&M, but at the present time, the E&M guidelines say 99203 is a detailed exam. So what constitutes a detailed exam? Here, I'll show you right here. Oh, a little too fast here. So here, you see, 99201 is 1 to 5 findings. 99202, 6 to 11. 99203, 12. 99204 and 99205, oh boy, it gets complicated here. According to the E&M guidelines, you have to perform all elements identified by a bullet. Got to document every element in each box with a shaded border and at least one element in each box with an unshaded border. Oh boy, what are these borders and bullet points? So if you're not billing 204 or 205, don't worry about it. And we're not going to get into that too deeply, but I want to get into 203. So yeah, these are the, if anybody would like a copy of these E&M guidelines, just send an email to amy@targetcoding.com. That's AMY@targetcoding.com. We can mail you these E&M guidelines. I don't know if you're going to want them. They're about 90 pages, but there's a, specific pages on a musculoskeletal exam, and then you see these shaded borders and bullet points. So that's what I'm referring to here. So now, I mentioned earlier, being a chiropractor, 16 years in practice, know what it's like to be in the trenches, treating patients and dealing with all that stuff. And now, an expert in billing and coding, I can give you what I call my 12-point exam. You have Mrs. Jones, she comes in, and what does she have? She has neck pain and back pain. So you see the 4 things you see on your screen: palpate, subluxation, range of motion, check for muscle spasm. You do those 4 things in the neck and the lower back. There's 8 findings right off the bat. See how quick? I got you 8 findings. Now I know some chiropractors, they stop here. They get 8 findings and they stop. Okay, then that's a 202. See, 99202. Now, if you need 4 more findings, I'm assuming some of you check posture. Come on. I think every chiropractor should check a patient's posture. I really feel that should be a standard test. I don't think dermatologists check for posture. They don't need to. So check posture. I don't know. Check the skin. You want to check the skin. That, skin of the neck and back appear normal. There's 2 findings. Patient appears oriented to time, place, and person. There's another finding. Patient's gait is normal. If you do vital signs, do 3. So you should be able to get a 99203. Now, this is what some of you are getting. You're seeing a patient 5, 10, 15, 20 times, and then you get this denial in the mail from an insurance company. The services are denied because they were not medically necessary. So here we go. Now, you billed an insurance company. You thought it was medically necessary. The patient thought it was medically necessary. Now you have a health plan saying, we don't think it's necessary. Now, just the statement, not medically necessary, means nothing. At least it means nothing to me. It just means denied. It doesn't tell me why. It just says it's not payable because it's not medically necessary. It's too vague. It's not a good answer. It's like getting pulled over for speeding and the police officer says, all right, I'm giving you a ticket. And you go, okay, police officer, how fast was I going? And the police officer says, I'm not telling you. And then you go, well, what's the speed limit? Police officer says, I'm not telling you how fast you were going. I'm not telling you the speed limit. Here's a ticket and you were wrong. Now deal with the ticket. So that's what this means. You send in a bill. The insurance company says, we're not paying. We're denying you because we feel the care is not medically necessary. Means nothing. That's too vague. You need to dig deeper and deeper and deeper and deeper to find out the reason. And what I've given you here on the screen is some of the more common reasons why the claim would get denied. Not enough improvement. Insurance company says, we looked at your notes. We don't feel the patient is improving enough. Therefore, the care is not medically necessary. Next, the goals have not been established or reached. Therefore, it's not medically necessary. Dr. Smith, you billed us for therapeutic exercises. You didn't write down how much time you spent doing that. Therefore, it's not medically necessary. Dr. Smith, we looked at your notes. They're not legible. We're not paying you. If your notes are not legible, therefore, it's considered not medically necessary. Dr. Taylor, we looked at your notes. Your notes look verbatim. Every note looks exactly the same. Therefore, we consider the care not medically necessary. So these are some of the more common reasons why, and hopefully you have a good fight back, a good pushback, and you know, unless you got caught with your hand in the cookie jar. I mean, you know, there are some doctors. I mean, there's one doctor right now I'm working with from North Carolina. Insurance company wants money back. Usually I can find stuff to fight back. 99% of the time, I usually can find some ammunition to help the doctor. This doctor, I just had nothing. The notes were so bad. So doctor's got to, you know, lick his wounds and move on. Usually, you know, there's something to fight back. Next, your care is maintenance. Oh, it's maintenance? Really? What's maintenance? Depends who you ask. Ask you, ask me, ask your teachers, ask your, you know, ask the insurance company, ask your practice management consultant. Who are you going to ask? What's maintenance care? I don't know, let's ask Medicare. Medicare says chiropractic maintenance care is not payable. And you would think they would pay for it because listen to their definition. It says maintenance includes services that seek to prevent disease, promote health, and prolong and enhance the quality of life, maintain and prevent deterioration of a chronic condition. They don't pay for that. Sounds like a good thing, right? You know what I want everybody to do? You see that street? Take out the word maintenance therapy and replace it with chiropractic. It'll make you feel better. Chiropractic includes services that seek to prevent disease, promote health, prolong and enhance the quality of life, maintain and prevent deterioration of a chronic condition. Yes. That's a great definition of chiropractic. Now at the bottom, do not use the wellness code for Medicare. The S8990, do not use that for Medicare. I know some doctors have been told to use that. It doesn't work. I've tried it. You know what's nice about what I could do here at Target Coding? I can convince some of my clients to be guinea pigs and submit stuff for me to insurance companies to see if it works. It doesn't work. So again, Mrs. Jones, you've reached maintenance care. It's not payable by insurance. Now, there's only two categories of patients in your practice. Everyone listening to this, invite me to your office. And you know what? I could walk into every single treatment room and I will categorize the patient for you into one of two categories. Category 1, active care. Category 2, maintenance wellness. There's only two categories. Now, some of you call it rehab care and wellness care, the acute care, the corrective care, all the different phases of care. You know, I look at it differently. There's two phases, active or maintenance. Active care, you know what that is. I went through that with you already. Pain, discomfort, restricted motion, can't do activities. That's active care. Insurance pays for that. Or if the patient doesn't have insurance, they pay out of pocket. Or patient feels great, very little pain. Yeah, that's maintenance care. Playing tennis, maintenance care. That's cash. I have on here, don't get caught in the middle. Many of you, I know this is happening. Many of you are billing insurance and your notes look like it's maintenance, but you're billing it and getting paid for it as though it's active care, medically necessary care. It can come back to bite you in the butt. Don't mess around. Don't take chances. It's not worth it. Is it wellness or not? Explain to the patient. You're reached wellness, Mrs. Jones. It's not covered by insurance anymore. Don't hold back. Oh boy, yeah. Seen a lot of these letters, audits. Doctor, you want $250,000 back. Oh, I don't know what happened to this slide here. Yeah, this doctor got lucky because he was billing it as though it was active treatment, and the insurance company asked for the notes. They looked at the notes. They could have asked for the money back. They could have done a lot of damage to this doctor. You know what they said? We're not going to do anything but put you on a prepayment audit. We're not going to ask you for money back. We're not going to make you go through a corrective action plan. We're not going to report you to the board. We're not going to do all these other things that they could have done. So we're just going to put you on a prepayment audit. So starting at a certain date, it's got to send in the notes with the bills, and it's better than giving the money back, but it causes chaos. It causes a lot of confusion when you're on a prepayment audit. So hopefully you prevent that. And one of the best ways to prevent that is to have good policies, good procedures, good financial policies. Like, what's your policy on collecting co-pays, deductibles, and co-insurance? Are you allowed to waive co-pays and deductibles? I know all of you are saying no. Once in a while, it's okay. Once in a while, it's okay to waive a copay or deductible. It should be done sparingly, and the patient should have a reason, namely a financial hardship. Once in a while, it's okay. Guess what? I gave a patient care for free once. She was a patient. She said she just lost her job. She was in bad financial shape. She was a single parent. I said, no charge. She signed a form. I gave her free care. I didn't do it across the board. I didn't say every teacher that comes in, no copay. Every fireman that comes in, no deductible. Every patient that works for Merrill Lynch, we don't collect any copays. Any patient that works for Bank of America, you don't have to pay anything. That's illegal. That's inappropriate. Yeah, this doctor got a letter from Cigna. Might be hard to read. I'm seeing a lot of these now. If you are waiving copays and deductibles, here's a trend. I'm seeing this. This insurance company says, we want to see copies of the patient billing and collection ledgers. We want to see documents that show when bills were sent to the patient, if any, and how much money has been paid by the patient. Oh boy, this doctor wasn't collecting anything. Okay, that's a problem. What about discounts? You have a policy on discounts? You have a policy on free exams? Are you allowed to give away free exams? Here's our, yeah, if anybody wants a copy of our financial policy, here, just send an email to amy@targetcoding.com, AMY@targetcoding.com. We'll send you our sample financial policy. And, you know, this is hard for a lot of people. You know what's funny? About 30% of the doctors I work with, they don't treat maintenance. They don't treat wellness. You just tell patients, you're in pain, you're hurting, come in. You're not hurt, you know, they don't get into it. 70% of the doctors I work with want patients coming in for those monthly little tune-ups and oil changes, right? Those are great. Aren't those the best patients anyway? Patient comes in and says, I love chiropractic. I love coming here. I have no pain. I'm here to prevent problems. Please adjust my spine because I want to maintain my health and wellness. I'd much rather have a patient like that than a patient coming with screaming sciatica that could hardly walk. I'd much rather have that, hey, I'm here, I just need a tune-up, and it's cash, right? So, yeah, here's a transition to wellness. This is what we do in our CA boot camp at Target Coding now. We offer CA boot camps on patient relations and front desk, and on billing and coding, and on back office and therapies and soap notes. CAs doing soap notes, yes. We train our CAs to do the soap notes, and on compliance. So we have our CA boot camp, and this is part of the script. Good news and bad news. Yes, right? This is a patient that comes in and says, I'm covered for 30 visits. Well, Mrs. Jones, sorry, your plan now deals with a company, a managed care organization. Well, I'm covered for 30 visits. Mrs. Jones, have you ever heard of managed care? Mrs. Jones, your insurance company has a relationship with X company.
It's a managed care organization or a third-party administrator. Yes, you used to be covered for 30 visits, but your plan has changed. We now need to pre-certify, pre-authorize the visits. We should be able to get the first 5 approved, and then we'll need to do a reevaluation. That's just the way it goes with managed care. So hopefully you have a good script. You want to have good, proper billing and coding policies and procedures. Hopefully you know, when you're dealing with Medicare, I see a lot of doctors, they get confused when it comes to Medicare, and they think that everybody has Medicare Part B. For example, I don't know, quite a few doctors, they go, oh, Marty, I don't treat Medicare. Medicare patient calls in, you know, we tell them, no, we don't deal with it because they only cover, that's only spinal manipulation. Well, that's Medicare Part B. You know, I'm going to give everybody a little crash course in Medicare A, B, C, and D. So when somebody turns 65, you automatically get Part A and Part B. Part A is hospital coverage. Part B are doctor's visits. So here comes Mr. Smith, comes into your office. He says, you say, hi, Mr. Smith, welcome to the office. How can we help you? He says, I have back pain. And you say, what insurance do you have? What does he say? I have Medicare. Mr. Smith doesn't know that Medicare is not an insurance company, right? Medicare is not an insurance company. Medicare is a federally funded program. If Mr. Smith was a patient in New York, that's National Government Services. That's the insurance company. If the patient is, you know, in Texas, that's Novitas. If the patient is in California, it's Noridian. If the patient's in Georgia, it's Palmetto. If the patient is in Wisconsin, it's National Government Services, right? Indiana's WPS. So, Mr. Smith, what insurance do you have? I have Medicare. Well, Mr. Smith, let me see your card. Mr. Smith hands you this red, white, and blue card. That's traditional Medicare Part B. That only pays for spinal manipulation. Now, Mr. Smith may want to opt out of Part B. He might. Now, this is the open enrollment period. In your local newspapers, you might be seeing tons of ads right now for United Healthcare and Care Plus and Aetna and Blue Cross Blue Shield. These are all Medicare Advantage plans, Humana, AvMed, tons of simplified, all these Advantage plans. So a patient could opt out of Part B and Part A and go into Part C. Part C are Medicare Advantage plans, also known as replacement plans, Advantage plans. Part C all means the same thing. And Part D is prescription drug coverage. So now, here we go. Next patient walks in. This is Mrs. Miller. Mrs. Miller walks in the door. Hi, Mrs. Miller. How can we help you? I have back pain. What insurance do you have? Mrs. Miller says, I have Medicare. Okay, let me see your card. And then she hands you. You see on your screen that United Healthcare or that Blue Cross Blue Shield Medicare Advantage plan. Everything's different now. You don't have to be enrolled to see Part C. Part B, you need to be enrolled. By the way, doctors, if you are not enrolled in the Medicare program and billing Medicare for spinal manipulation for Medicare Part B, you are performing an inappropriate activity. You have to be enrolled and you have to bill Medicare Part B for spinal manipulation. So don't be one of those chiropractors that says, oh, come on in, Medicare Part B. We don't bill. We don't do anything. We're cash. Lie down. Just pay cash. You can't do that. And then supplemental picks up 20% of the Medicare Part B allowed amount. And then you have secondary. Go back to John Smith. He's the Medicare Part B patient. And you say, Mr. Smith, Medicare doesn't cover exams. Our exam is $100. How would you like to take care of that? Mr. Smith might go, wait, what are you talking about? I don't pay. When I go to my medical doctor, I don't pay for exams. Well, Mr. Smith, you have traditional Part B that does not cover chiropractic for exams. I know. It's not right. It's not fair. It's $100. And Mr. Smith goes, well, my wife works. My wife works for the post office, and they have Aetna. You see secondary in the bottom right corner? Yeah, so maybe you want to have the Aetna pay for the exam. That's up to you. All right, so now here I figured I'd show you what a medically necessary claim form looks like. This is medically necessary bill going to an insurance company for a chiropractic adjustment, manual therapy,
electrical stim, and therapeutic exercises. See, I have some clients, all they do is adjust. I have one client, she sees 80 patients a day. All she does is adjust. No traction, no therapies. She's with the patient for 60 to 90 seconds. 2 minutes is a lot for her. She goes into the room, she does her adjustment, she's out. It's a 98940. That's it. Very simple. The note, I created a handwritten SOAP note for her because having her document in a software program would take too long for her. It's much easier to use a paper note form. It takes her about 10 to 12 seconds to do her note on a paper form that I created with her. So her claims and bills are very simple. 98940. This is 98940. Manual therapy. You'll see how I'm pointing. The adjustment is to the lower back. The manual therapy is pointing to the neck. And then we have the electrical stim also on the thoracic region and the exercises on the lower back. So you're telling a story. It's medically necessary. Here's another medically necessary claim. Now it's Medicare. Initial visit, you see your 99203, 25 GY, and then your adjustment with the AT modifier, medically necessary. And then the patient gets to wellness maintenance, and they check option 1 on the ABN form. Oh boy, I'd rather they check option 2, but okay, they check option 1. So now you have to bill. You see, there's maintenance care right there, 98940 GA. So we got the maintenance, we got the active treatment right there. And then we have, now we have patients that go, hey, I have a health savings account, or I have something, give me a receipt, give me something for, to submit. So there's no codes, right? There's no codes. We train our clients to have 3 types of statements. This is statement number 1. This is a statement without CPT codes or diagnosis codes. See, exam, adjustment, no codes. Then we have another. We have a statement with codes. So now this is not a 1500 form. This is just like a walkout receipt or statement. This is with codes. Exam 99203, adjustment 98940. And then we have a maintenance care statement with codes. There's the wellness code, there's the diagnosis. So we have all bases covered based on those 2 categories, active and maintenance. What is the patient? Active? Okay, we got to follow rules. Even if it's a cash patient with active treatment, it's different. I don't know, if you realize the difference, if the patient is a cash patient with symptoms and cash patient without symptoms, the documentation it could be different, could be very different. I recently got approved to teach risk management courses. I've been teaching billing, coding, and documentation for the last 10 years. Now my seminars have recently been approved for risk management and medical errors. So the documentation, even for a cash patient, has to meet the minimal standards of practice for your state. So big difference there. So financial policies, again, written financial policies, they help patients understand the difference between acute care or chronic care or maintenance care, however you want to word it, the phase of care, gets patients to understand they are responsible for a portion of the bill. It prevents upsets. Got to, just educate the patient. Keep fees simple. Keep fees simple. Fee confusion is one of the most common causes of complaints to the board. If your CA, your front desk CA, is kind of rude or abrupt to a patient, the patient is not going to file a complaint with the board. If your office smells like Chinese food, they're not going to, the patient is not going to complain to the board. But if you mess with their pocketbook, you overcharge a patient, or if they think you're ripping off their insurance company, quote unquote, they will file a complaint. Patients are protective of their insurance companies. If they think you're overcharging, they may call their insurance company. It's funny, just about every seminar I go to, one of the chiropractors will come up to me and show me a medical bill. Just recently, a client of mine came up to me and he's like, Marty, my wife went to this medical doctor. Look how he charges. He was charging 2 E&M codes and showing me all the different things that, and he was upset. He wanted to like file a complaint against this medical doctor for overcharging his wife. So fee confusion. And here's another thing I always recommend. If you are not using ChiroHealthUSA, which I don't know why you wouldn't for all your cash patients, it's the easiest way to allow you to charge a fair fee without violating the dual fee schedule. So you should make patients aware of your normal fees. And then if you're going to give them a discount, explain your discounted fees. Otherwise, the patient could have what I call sticker shock. Let me explain this to you. If you are charging your cash patients, let's say $40 for a visit, and you don't tell them your normal fees, now the patient's coming in, right? They're paying their $40 cash. They think that's your fee. And now let's say the patient disappears for a while, and then they come back and say, Doc, I was in a car accident, or I got health insurance. I was paying you cash. I got a job. I have health insurance. And now you're billing the insurance company $200 a visit. The patient could go, whoa, it was 40. Now that I have insurance, it's 200. The patient could get upset, right? The patient can get upset and go, what the heck? I thought it was 40. He's ripping off my insurance company. Careful. Educate the patients. It's important now more than ever. Get patients to understand they may not be able to use all their visits. So just a few, I'm going to close today with a few closing comments. I like to call it my 9-step action plan. Step 1, get proactive. Don't wait for the oil light to flash on your dashboard. Get out of the car, open up the hood, right? Do a lot of the things I'm telling you now. Have staff meetings. Log in your staff trainings. Go over this with your staff. Make sure, step 2, doctors, make sure your staff, this is more for staff, step 2, make sure all those new patient forms are completely filled out. Every single form. If you have a body diagram and you want the patients to circle or dot or X the areas of pain and they don't, give the form back to the patient. The patient didn't put in how long they've had the pain. I have a doctor being audited right now for TENS machines. The doctor wasn't writing down how long the patient had the pain because it's chronic pain for TENS machines. It doesn't say anywhere on it actually had on the intake form, how long have you had this pain? Patient left it blank. All the patient had to do was put down how long, and there wouldn't have been an issue. So step 2, get all the forms filled out. Step 3, this for the doctors. Doctors, review all the paperwork. Again, this is my risk management malpractice prevention brain here. Look at all the paperwork before you go into the room and start adjusting the patient. Make sure you review all the paperwork that they filled out. Next, step 4, review the policies from the insurance companies you bill the most. I kind of touched on that earlier. Step 5, understand the what and the why. What are your CPT codes? Why are your diagnosis codes? So what are you doing? A chiropractic adjustment? Why? Because the patient has a subluxation. Oh, what are you doing? Mechanical traction? Oh, for what? Cervical radiculopathy? You see, those pair. You want to pair your procedure codes with your diagnosis codes and know the clinical rationale. Step 6, do a self-test on your SOAP notes. Find out what a medically necessary SOAP note looks like. If you want, we could email you one. Email amy@targetcoding.com and we'll email you one of our sample, what we consider the perfect SOAP note. It could pass any note, any insurance company, Geico, State Farm, Allstate, Aetna, Cigna, Medicare. Step 7, always keep learning. Always keep learning how to help more patients, improve your business. That's why you're listening to this, right? Step 8, put together a simple billing policy manual. If you're billing insurance $250 and now your cashier's only charging $50, wait a second. You want to do that? You have to use ChiroHealthUSA. ChiroHealthUSA is the only way to get around that dual fee schedule that a lot of doctors have, and they don't even realize they have it. Just had a phone call with a doctor this morning. He's so off, and I asked him,
who told you that? Where did you hear that? Did you? And it's like, doctor just made it up. I wish he would have said, I learned it from this practice management consultant, and I would have called that practice management consultant and said, hey, can you explain why? And I've done this. Can you explain why you're telling these? I just want to know your premise. I'm not going to say it's good or bad. I just want to know why you're recommending it. How can you recommend an exam and x-rays for $17 when you're billing insurance $250 if they haven't, So I just like to know why. This doctor is like, I just made it up. I charge this. A patient pays me $60. I give him a walkout receipt for $100. I had one client. He tells me he's having the patient pay $150 a visit cash. It's like, wow, that's great. $150 cash. This doctor's in New York City, so maybe it's not a surprise. He's giving the patient a walkout receipt to submit to the insurance for his normal fees of $325 a visit. The patient is now getting a check from the insurance company for $250. So this patient is making $100 every time the patient comes in. The patient is making $100. You see how all these things. So make sure you have a simple billing and coding policy that explains. Some of you adjust full spine, but you only bill 98940. That ain't right. Number 9. Conduct regular meetings, specifically with the members that do your billing. If you use a billing company, do a spot check on them. By the way, Target Coding now does billing. We just started doing that. We offer billing services. So now, yes, I'm working with 2 doctors right now. The billing company was adding the modifiers 59 on codes that didn't need it. It caused an audit. Have regular staff meetings with your staff that do your billing. Make sure you are doing everything right, or at least attempting to do things right. You want to do this so you could SWAN. There it is, my favorite acronym, sleep well at night. So I want to thank everybody for attending. Now, besides these webinars, we also offer videos and services and compliance plans. We install compliance plans. We have a chiropractic compliance plan that includes HIPAA, billing and coding, OIG, and OSHA. We have memberships. We offer a $99 a month pay-as-you-go, no contract membership to stay in touch with us. We do seminars and webinars and on-site trainings. We have ASH. A lot of people need help with ASH. It's a 90-minute live training. You pick the day, you pick the time. This is our compliance, our chiropractic compliance program. Hondas are fantastic cars. I love Hondas. Great cars. We sell Mercedes. Our program costs more because we do more. We do all the heavy lifting for you in our compliance plan. We do seminars on cruise ships. We had our first annual last year. We have our second one coming up. Maybe you want to attend. We sell forms. I don't care if you have ChiroTouch, Eclipse, Genesis. Doesn't matter. You still need letters of medical necessity, hardship forms, ABN forms, HIPAA forms. We do soap notes. We do a checkup on your soap. Some doctors go, Dr. Kotlar, I don't need books. I don't need forms. Can you just check my notes? So we'll do a soap note checkup, and we have videos that we offer. So I just wanted to let everybody know what we offer. We also offer free consultations.
Thank you, Dr. Kotlar. Can you hear me now?
Yes.
Yes, well, it probably would help if I made sure that my microphone was plugged in.
Oh, good. So it was your fault, not mine. Thank you.
It was definitely my fault. We just installed all new equipment in my office for recording and video. And yeah, so the microphone wasn't plugged in. So thank y'all so much for going with the flow. I know y'all could hear me talking through the speakerphone to Dr. Kotlar at the beginning, and it started off a little different. And Dr. Kotlar, thank you for jumping on in there and taking the reins and for doing this webinar presentation today. Y'all definitely go visit targetcoding.com. It is a phenomenal website. He has incredible resources. I'm pretty sure there are some days that Dr. Kotlar thinks, I wish I wasn't the go-to man for Christy sometimes, because I ask 1,000,001 questions, but he always has an answer. And hey, if you want to go on a cruise and get some continuing education docs, check it out because ChiroHealthUSA will be on that cruise with Dr. Kotlar. We are so excited. We went on the last one, and right now everybody's fighting and arguing over who's going on the next one.
That's good. Yeah,
So, again, don't forget to reach out to Amy at targetcoding.com to get the sample soap notes and to get a copy of the sample financial policy. Again, Dr. Kotlar and his team are excellent resources for answering questions. They have incredible webinars. They provide incredible seminars. So make sure you check them out. Follow them on Facebook. Trust me. They're, again, one of my go-to resources. Be on the lookout because Dr. Kotlar will definitely be back in 2020, even though he is forgiving me for having my own technical issues. And he's like, I think it's me. And I'm like, no, I think it's me.
Now, Christy, are we taking, did questions come in? Are people allowed to ask questions?
Yeah, I've asked them to go ahead and submit questions. What I'm getting right now are emails that say this is an excellent webinar. I did see one while I had to restart that said the guidelines that you were talking about earlier in the presentation, where can they request those?
Oh, also Amy at targetcoding.com. No problem. We could, we're talking about the E&M guidelines. No problem. We'll send them to you.
Wonderful. So yes, reach out to Amy at targetcoding.com. It was great because that question popped up and then they were trying to help each other and somebody was like, I can never get that answer question, a question answered when I've asked it before. So yes, reach out to Amy. I do that a lot too. And I don't think there are any other questions. If you think of questions after the webinar, you can email Dr. Kotlar at targetcoding.com. You can email me and I will forward it to Dr. Kotlar at targetcoding.com. Because I notoriously think of questions 30 minutes a day after a webinar. So don't think that just because the webinar was today and you think about this question a day or two from now, you can't reach out to us and let us know. And we won't get an answer for you because I'm always happy to do that. So Dr. Kotlar is wrapping up the November webinars because next week is Turkey Day. So our next webinar will pick up on December 3rd with Dr. Todd Pickman, why and how to add corrective exercise to your chiropractic practice. Many of you probably registered for that when it was scheduled the first week in November. And then Dr. Todd Pickman and I both had to reschedule flights to San Diego, going up a day early. Originally, we were scheduled to fly in on Wednesday for a meeting, and we had to fly up on Tuesday, so we had to move his webinar date. So be sure to go to ChiroHealthUSA.com/webinars. We have webinars already scheduled into February of 2020. So go ahead and register early to reserve your seat. Dr. Kotlar, I hope you and your family have an amazing Thanksgiving.
Thank you, Christy. Wait, before you go, the next time we use Webinar Jam, should I just do the same thing I did, or do I have to practice with you? So we don't
it should work just fine. And I think, like I said, it was the first time you log in, it's a little slow to do. So I think we'll be okay.
Okay. And the next time we'll have the webcam going too.
Yes, we will, because Dr. Kotlar is under construction right now. So
Yes. The walls are gross with paint all over the place. So, and I didn't shave. I didn't shave this morning. So.
That's funny. That's my favorite holiday thing. Like when I'm off at Christmas, my husband is like, stop painting the house.
Right.
That is like my favorite to do. And we joke all the time that they're going to get me like some kind of fun panel because normally what y'all can't see is the mess around the bottom of my desk of all the stuff I'm trying to catch up on. So.
Okay, good. So I'll be ready next time. And you like this Webinar Jam company? I never heard of them.
I love them. They're awesome.
Okay, good. I got to check them out.
They are so cool. All right, everyone. Y'all have an awesome day and a great rest of your week. Dr. Kotlar, stand by for just a second.
Thanks.